dealing with an arterial bleed or a venous bleed. The meninges we've been over, the dura, the arachnoid, that's fine. But when we're dealing with traumatic injury or insult to the head, particularly the temporal lobe, the temporal bone, the artery that's most exposed there is the what? Right here. Middle meningeal artery, yes. It lies between the dura and the bone. So the epidural hematomas are most likely arterial in nature. Unfortunately, because of their high pressure, they have a tendency to bleed or to create a space-occupying lesion faster, so they have to be corrected faster. Many will say within less than 2 hours. If you don't correct them, then they can lead to death pretty quickly. Of course, like any acute space-occupying lesion, you're going to have headache as the presenting complaint, and then focal neurologic signs as the enlargement occurs.
All right, who's got the beef jerky? Brad, is that you?
Somebody needs to. Eggs. I had eggs.
Oh, no, it's beef jerky.
No, it's not.
I'm beef jerky.
It's not beef jerky.
Throw up.
It's not beef
I
jerky.
can't stand it.
That's it.
No.
Okay,
Hey, continue on.
like an intracranial bleed. So, next to epidural hematomas, you have subdural hematomas. The dura, as you know, contains different lamina. If you remember how the venous sinuses are formed, there's a periosteal layer, and then there's another layer, a meningeal layer, that splits. So the dura can split. A subdural hematoma occurs a subdural hematoma so if this is the split and the formation of a venous sinus there, and here is the arachnoid underneath there, like that. A subdural hematoma occurs in here, right below the dura, particularly with veins called bridging veins, which are on that illustration there. You see that large vein coming off of the arachnoid going into the venous sinus. That would be a bridging vein. So subdural hematomas are typically venous. They leak slower. They can be, what slide did you say it was?
30.
Yeah, here's the here's the bridging vein is right there. So you see here the arachnoid, which is on top of the sulci. These would be the veins that are injured in a subdural, there's the dura, subdural hematoma. Now these things occur also from blunt force trauma to the head, although because they bleed much slower, they can take months to develop. One of the things that you do in the emergency room when somebody receives a blow to the head, particularly a child who's fallen off a bed or something, they're always falling, is you want the parent to be aware that while there is no obvious bleed, intracranial bleed at the present time, you want them to check to make sure that one doesn't develop over the next 12, 24 hours by doing frequent neuro checks. So you send the kid home at night you have mom get up every 2 hours to go in there and make sure that she can awaken or rouse the kid. If she can't, then you need to get the kid back into the ER. Now, of course, because these things are slow growing, when they first visit the ER, the CT scan that you're gonna get is probably gonna be negative. But you're going to have them do neurochecks through the night to make sure that nothing develops, okay? Understand that with an epidural and a subdural bleed, if I do a spinal tap and draw CSF out of the subarachnoid space, there will be no blood. There will be blood, though. Wow. There will be blood, however, in a subarachnoid hemorrhage, which is typically venous as well. It can be arterial, for example, a ruptured aneurysm or an arteriovenous malformation. So you don't know if these are venous or arterial. But the things you have to watch out for is that because of the increasing pressure, particularly if they're arterial in nature, is that if you do a spinal tap with this increased intracranial pressure and you release pressure down here, you might wind up with an uncal herniation. Because you've got all this pressure up here, it's just going to push the brain right through the foramen magnum or through the tentorium, and you have a transtentorial or an uncal herniation. And these are not, or a tonsillar herniation. These are not going to be good things. So before you do a lumbar puncture to rule in or out a subarachnoid bleed, make sure you get, now what is it doing now? It's on some automatic timer. Oh my gosh.
This day is just, how do I get around to use timings? I don't want to use timings, slow, I don't want to say that, I don't want to play narration. Oh my, it's sped up. Maybe we're okay. Will somebody text Amber and tell her that the world is falling apart? Okay, so hypoxic encephalopathy basically is just saying that anytime you have an injury or insult that decreases the blood supply to the brain, either by asphyxiation, drowning, or some event like that, you're going to have obvious problems, particularly in the hippocampus, which is a thing that we're going to talk about later, which is involved in memory. So that's one of the first things to go in chronic ischemic insults. Now, obviously, acute insults like a drowning are more serious. However, drowning in ice-cold water is better than drowning in Lake Eufaula because of the decrease, a sudden decrease, or the mammalian diving reflex, which shuts down your physiology and protects your vital systems. Okay? Okay. All right. One thing about hypoxic events, though, is right here before it changes, that when you have a hypoxic event like a stroke, and you send that patient to rehab, the symptoms that, the function that you get back during rehab are limited to about the first year after the injury. At the end of the first year, whatever deficits you have are probably the deficits you're gonna have for the rest of your life. But, you know, they talk, you're always asked, you know, is my child or Uncle Joe gonna get better? The answer is, you know, I don't know, but we're going to have to look at recovery over time. Surely some things may come back, and we're looking at a year. Which one do you hit?
I didn't hit it, all I hit was escape. So I don't know if there's another mouse interfering with this, like there's no timer set.
Well, this is not working.
It's not the mouse. It's the automatic.
The present chair's view is on automatic. If you change that, probably that will help.
Oh,
Really
okay.
good.
Did it not right? Yeah.
And it goes on a.
I'm making that work first.
All right, so, let's see, go back, can you go back one slide? All right, so this is the next slide, right? All right, so let's talk about strokes for a minute. There are 4 types of strokes. There are 2 broad categories, 4 types, each having 2 types. You have ischemic strokes on one side, you have hemorrhagic strokes on the other. You see the numbers there, 87% ischemic, 13% on the hemorrhagic. When I was in PA school, those numbers were reversed. Because of stroke therapy, hypertension therapy, we really cut down on the number of hemorrhagic strokes. This is good in that hemorrhagic strokes are the ones most commonly leading to death in the first hour following the stroke. If you look at ischemic strokes, the 2 types are thrombotic. So thrombotic, you can, you put your stethoscope right here, the bell, and you hear a bruit in the carotid artery. Over time, that carotid artery just closes off. The same thing can happen in the middle cerebral or any of the circle Willis vessels. You just get a gradual closing of a vessel until it clots, until it completely closes. That's a thrombotic event. Those things, at least in terms of atherosclerosis of the neck or the carotids, occur quite frequently in the geriatric population. It's impressive how many bruits you'll hear. However, the strokes that occur on the ischemic side are usually more embolic in nature, in that fragments of these thrombotic plaques will break off, or you'll have a patient, an elderly patient, in atrial fibrillation, which a lot of elderly patients are in AFib, developing clots within the left atrium, goes to the left ventricle, out and into the cerebral circulation. So embolic strokes are probably the most common of all strokes right now. Stroke is also called a CVA, cerebrovascular accident. On the hemorrhagic side, you have 2 types. You have intracerebral, so you have small little striate arteries that come off of the middle cerebral. If this is the middle cerebral right here, here's the internal carotid, the middle cerebral comes off there. You have these tiny little arteries that come off there to supply deep brain structures. If you do the physics here, the pressure coming out of the heart at the aorta is 120 out here is 120 millimeters of mercury. Here it would be higher. Okay, so as you know that as you decrease the diameter of a tube, the pressure inside the tube goes up exponentially. So you've got these tiny little arteries right here called striate arteries that supply deep brain structures that are this far from a high pressure system. So the pressure in those little arteries is huge. That's why hypertension was the big thing about intracerebral bleeds. If you have a stroke involving a striate artery, because it involves a particular area of the deep brain, it is called a lacunar infarct. A lacunar infarct. when we get to tomorrow's lecture, and I talk about what's called the internal capsule, remind me to mention that lacunar infarct again, so you can tell in a patient that you're having a lacunar infarct versus an infarct of, say, the middle cerebral. Okay, remind me to explain that tomorrow. Extracerebrals would be from, as it says here, aneurysms or AVMs or venous malformations. Not arteriovenous malformations, but venous malformations in the subdural, in the subarachnoid area. These are the risk factors for stroke. There are 50 billion risk factors. You really don't have to worry about these three because there's nobody in Oklahoma with diabetes, and no one smokes here. There's no hypertension. Protein C and S and factor V Leiden are hypercoagulable states. An absence of, or a genetic defect of protein C or S, or a mutation of factor V Leiden create a hypercoagulable state. Oral contraceptive pills, not so much so now, since they've decreased the hormone content, but you still would not put a woman over the age of 35 who smokes on oral contraceptive pills. All right, so you have to take all these things into consideration.
Just making sure you're bringing it up.
You gonna take notes? All right, stroke
Zone
consideration.
out.
Stroke considerations. The Cincinnati pre-hospital stroke scale is right here. And it looks at three things. One is, if you're out and about, or you have, you're eating turkey with the family, and all of a sudden Uncle Junior says, my face is drooping right there, and they start having slurred speech, and if you get them to hold their hands up like that, palms up, and close their eyes, and one palm drifts like that, that's called pronator drift. If you get one of those three, then you have a pretty high chance here of having a stroke. If you have 3 out of 3, you're almost certain to be having a stroke. That's called the Cincinnati Pre-Hospital Stroke Scale. If you look at strokes, ischemic strokes, so we're talking about thrombotic or embolic strokes here, why do they come to the emergency room? They come to the emergency room because they're having some kind of focal neurologic sign. Their face is drooping, they have muscle weakness, they have paresthesias, something's going on. Big time focal neurologic signs. Do they have a headache? No, not necessarily, because they're not increasing the volume of the intracranial content, except for these little striated arteries, which is not a lot of blood. You're talking millimeters of blood here versus something like an extracerebral bleed. Loss of consciousness? No, not usually. Okay, intracerebral bleed, same thing goes. Intracerebral bleed, no headache, no loss of consciousness, because they're involving the blood supply to specific nuclear areas, you have focal neurologic signs. Extracerebral bleeds, on the other hand, the presenting complaint usually is headache. It's the worst headache I've ever had. You get a CT. Or if there's a headache and focal neurologic signs, you get a CT. Photophobia is not a focal neurologic sign. Anybody with a migraine will tell you that light hurts, it hurts. That's not a neurologic sign. But an absence of vision is a focal neurologic sign. All right, so this is a big problem when you deal with people your age, because if Alex comes in to the clinic complaining about this horrendous headache she's had since 6 o'clock this morning and is getting worse and is the worst thing she's ever experienced in her entire life, do I send her for a CT, which is going to cost her $600 out of pocket because she hasn't met the deductible, obviously? Or are we going to call this a migraine headache, or, my wife gets headache, menstrual migraines. Women get menstrual migraines a lot around their periods. Is this a menstrual migraine, or is this a exploding AVM or baryaneurysm? It can happen in people your age. I know people it's happened to. They're dead now. You cannot miss this. Okay, so one of the things is, you're gonna have to get a good history. When is, you know, if she says in her history, I have migraines associated with my periods, is this like that? Is the timing right? Is it in the same location? Is everything the same? And treat it as a migraine, send her home. If there's one thing different, send her happy butt over to, for a CT. Okay, even though you're gonna cost her month's rent, you gotta do it, you can't miss this. Yes, ma'am.
Definitionally, the difference between intracerebral and extracerebral, is extracerebral just anything that's not the striate artery? Or is it,
Extracerebral would be out here, subdural, like an aneurysm or an AVM. Intracerebral would be the striate vessels usually. Okay?
so anything that doesn't like go into,
I'm sorry?
is,
Well, so if you're looking at how these present, this is a geriatric person. This is a hypertensive person. That's a young person. That's a very broad generalization, but you can sort of think of it that way. All right. Infarction. This is thrombosis here. You see the primary area of necrosis in the cortex there. It says seen mostly in older individuals. That's what I was talking about. Now, you're going to have emboli that travel that are small, they're tiny, like little grains of sand. And they're going to go and block a vessel, and you're going to have a focal neurologic sign, but the area that they're blocking usually has enough collateral circulation that it'll eventually recover within a matter of hours to a day. So you might wake up and you say, I lost vision in my right eye. But 2 hours later, it's gone. I have vision again. Or I have weakness in this arm, but 2 hours later, oh, my strength's coming back. Okay, that is a type of stroke known as a TIA, a transient ischemic attack. You have to take these symptoms very seriously, because that means that things are breaking off here of the thrombi, and you better get them managed appropriately. Emboli, again, from the heart or the carotid arteries. The symptoms are really based on the size of the embolus and what vessel it's in. The thing is, though, if somebody is having a stroke, if you determine that they have a stroke, you get a non-contrast CT. You don't want to inject contrast material into a bleeding aneurysm in the brain. So a non-contrast CT. Once that is confirmed negative for bleed, a lot of times neurologists will get a CTA, angiographic CAT scan, where once the bleed is, there's not a bleed, we're going to inject some contrast material and look at the vascular pattern. If that's inconclusive, they'll do an MRI and an MRA to look at the blood supply of the brain. If there is obstruction from an embolus, recombinant tissue plasminogen activator is the clot buster or the thrombolytic that's used most commonly to dissolve the clot and improve outcomes. You want to get this on board TPA as quickly as possible, usually within 3 hours after the onset of symptoms. So if Grandpa woke up with symptoms, a lot of times they won't use it because you don't know when in his 8-hour sleep he developed the symptoms. Of course, the risk of using TPA is causing an intracerebral bleed, so there are other contraindications like recent surgery of the head, a recent hemorrhagic event, And so, or advanced age, a lot of people will not do it in people who are over the age of 80. So there are several contraindications. Non-traumatic hemorrhagic strokes. This is just an intracerebral bleed gone bad. You'll see that in addition to hypertension, there are other causes that can lead to bleeding. You know, one of the big ones here is leukemia. So that's kind of a sad thing. It says, unlike infarcts, hemorrhages are not confined to an arterial distribution. As you can see here, whatever started bleeding, probably a striate artery, has just expanded to involve most of that hemisphere. Obviously, this person did not survive this stroke. Berry aneurysms are frequent. One in 20 people will have one. It's a true aneurysm, usually involves a circle of Willis or one of the branches. Most of it is going to occur in the middle cerebral artery system. That's a little over 50%. The anterior cerebral and the anterior communicating artery junction is the other place where you'll find a high percentage of them. One of the ways to treat these things, and you can see the Berry aneurysm down here, is coiling. So what the interventional radiologist will do is go in through the arterial system with a with a wire, get all the way up into the cerebral, middle cerebral artery here. In this instance, they put a stent in there to keep the artery open, and then they coil wire inside the aneurysm. And the presence of that knotted up wire creates a blood clot around it, and essentially the aneurysm clots off, and you don't have to do the surgery. Of course, the other treatment for Berry aneurysms is to go intracranially and put a clip on that, the stalk. Okay? But this much less invasive procedure is done quite frequently. Integris, there's a woman out in Integris that is sort of the regional expert in coiling aneurysms in the noggin. Vascular malformations, again, in a high population of people, they come in two forms. They come when there's varicose veins, so venous malformations, and there are other malformations where an artery attaches to a vein without first going to a capillary bed, so you wind up with varicose veins that way. AVMs are much less common than venous malformations. Most of the time, venous malformations, you don't have to do anything with it. You see it, it's there, it's big, you leave it alone. It's the AVMs that you have to go in and fix because of their potential for rupture. I'd hate to be walking around with an AVM in my head because it's really a ticking time bomb. Although it's a pretty good way to go because you're going to go fast with an AVM, seconds, and you'll trot along and you're dead. Meningitis. Meningitis is something you're going to roll in, roll out 100,000 times. There are a bunch of different types of meningitis. The two that you're going to see most frequently are bacterial and more often viral. Viral meningitis is also called aseptic. And it's called aseptic because years ago, when they tried to culture the organism out of the CSF, they got no bacterial growth. But that was before the days where they had viral cultures. So they called it aseptic. But the correct term is a viral meningitis. All right, the problem with viral versus bacterial meningitis. Bacterial meningitis can be lethal. If you don't treat it, most of the time it will be. Viral meningitis is usually a self-limiting disease most of the time, and if you don't treat it, you'll get better in 5 days. You don't need to do anything about it. They don't need to be on antivirals or anything. You'll get better in 5 days. The problem is that they present exactly the same clinically, and you cannot distinguish them. Is this bacterial or viral? You have to rule that out. This thing right here is kind of important there, that if you're dealing with a focal neurologic sign, you're probably not dealing with meningitis. And because meningitis is an infection in the CSF, essentially, it affects all of the nervous system, all of the central nervous system, because of the flow of CSF. All right, bacterial meningitis, there are different organisms that can cause them. Haemophilus and Strep pneumoniae are two predominant ones, as well as Neisseria meningitidis. Neisseria is the one that you have to watch out for, particularly on college campuses. And there is a state law that if you live in a dorm, you have to be immunized against Neisseria meningitidis because of its highly infectious nature. Neisseria meningitidis produces a petechial, purpural rash that you see here on this little kid. It's a vasculitis, essentially, that produces these hemorrhagic spots. It can be quite dramatic, but anytime you see a feverish kid that's lethargic, won't turn their head, with this purplish rash here, they better be on a helicopter headed to Children's Hospital. Okay? Going back to this, you want to get, obviously, a lumbar puncture, spinal tap, to get CSF, to look at the various contents of the CSF, but also to culture, to get a culture and sensitivity of the fluid itself. You don't sit around and wait for determination if it's viral or bacterial. As soon as you get your CSF, as soon as you get your blood, because you need to do blood cultures too, you better be giving them a gram of Rocephin twice a day, until you get your sensitivity report back. Everybody understand that? Okay. Don't wait. But get your CSF and blood first. You can't give antibiotics and then get the fluids. You gotta get the fluids first. There are tons of symptoms related to meningitis. One of the things is they don't want to move their neck. So nuchal rigidity is big time a problem with meningitis. Spinal rigidity also, they want to extend their spine, take pressure off their spine. There are two special tests, physical exam tests, for meningitis, Koenig's and Brudzinski's. You need to memorize these two because they're board questions, obviously. So basically what you're doing with these tests, have you heard of these tests before? You have? Not in PA school. Okay. Basically what you're doing is you're stretching the meninges. You're putting stretch on the meninges, which you don't want to do if you have meningitis because they're so sensitive and irritated. So, Maddie, you're up again. Can I get you on the table here? So, face up. So the two tests here, Brudzinski's, it says passive flexion of the neck. Passive means you do it. Active means she does it, right? So passive flexion of the neck is when I take her neck and pull it up like this, if she has meningitis, so I'm stretching her cervical meningitis, what she wants to do is sort of curl up in a fetal position. So she kind of brings her legs up like this, trying to get the pressure off of her neck. Koenig's sign, though, is the exact opposite. We go down to this end of the thing, we're going to flex her hips here, and what she wants to do is bend her knees to take the pressure off of the stretch of the lower meninges. Think of that. Okay? Any questions about that one? Koenig's and Brudzinski's. All right. Aseptic meningitis. Well, a lot of bugs can cause aseptic meningitis. If we look at viral to start with, the viri that are most common, the echovirus is somewhat common. Poliovirus, fortunately, is no longer with us here in the United States because of immunizations against polio, but it certainly is a type of viral meningitis. and encephalitis. The two most common, though, that you're going to see really are rhinoviruses, which are typical cold viruses. They gain entry into the CSF, usually through respiratory channels, hematogenous spread as well, and Coxsackie virus. The pathognomonic thing with Coxsackie virus is the patient comes in with a rigid neck and they don't want to move, and they've got lesions like painful little vesicles inside their mouth, on their hands and on their feet. What the heck? That's hand, foot, and mouth disease. Okay, Coxsackie, board exam question right there. All right. You typically just don't leave it alone, and they'll resolve without sequelae. I mean, except for polio, of course. You have other viruses like herpes simplex virus that can gain access there. You know, the problem with herpes encephalitis or meningitis is when you're dealing with immunocompromised patients. You're not going to see this in a person with an intact immune system. But immunocompromised because of chemotherapy, HIV, leukemia, on and on and on, you have to worry about this. Okay, so if a patient presents with like herpes zoster, for example, shingles outbreak, and meningeal signs, you have to assume that you're dealing with a varicella meningitis. And these people need to be hospitalized in the ICU. Okay? There is a vaccine now. You know about the vaccine for zoster for people over the age of 60. It is indicated. I would certainly ask and encourage your patients to get that vaccine. I'm looking forward to the day I turn 60 so I can go get my vaccine. And I get another colonoscopy because I got one at 50 and that was good for 10 years. So I get the colonoscopy. And like if you've never had, anybody here had colonoscopy? Did I ask this before? Have I ever asked you that? Anybody? There's some people in here who've had colonoscopies. So they jack you up with Demerol and Versed. And I'm telling you, it's worth the colonoscopy to get that stuff. This is good stuff. More neural type infections, viral infections, rubella. We've talked about rubella in terms of maternal fetal transmission and making sure that the mom is immunized against rubella, German measles before the pregnancy. This can cross the placental membrane and into the fetal CNS, causing a tremendous number of congenital and developmental malformations. Rabies is a virus. It comes from mostly, in this region, skunks, bats, and everything else. You actually, one of the highest incidences of rabies worldwide comes from domestic cattle, but not in this country, in case you're on Jeopardy. We don't really have rabies much anymore because of the treatment, the prophylactic treatment against rabies once you've encountered a potentially rabid animal. And if it's unknown whether they're rabid, there's actually a protocol from the health department that you follow in the emergency room on whether or not a person is going to receive the rabies vaccination series. Okay? Any questions about that? If you look at rabies, though, if you do a YouTube thing on rabies and look at these people, it's pretty impressive how nasty this can get. The whole thing here, about rabies is aversion to water and hypersalivation. So, interesting. But I don't think in the U.S., the last time I looked, probably 5 years ago, there were, I don't think, any confirmed cases of rabies in a human being because of there were lots of cases of confirmed rabies in animals, but because they've been treated, it hasn't been transmitted to humans. Tuberculosis is another type of aseptic meningitis. Again, you're looking at mostly the immunocompromised. Interesting, this point here was that years ago, it was TB meningitis was very common in children. Unfortunately, if you don't treat it, there's a high incidence of death associated with it. And in certain parts of the world, you know about multi-drug resistant TB, which unfortunately provides a bad outcome for those that contract this outside of the industrialized world. Immunosuppression is the key word though here. Syphilis and cryptococcus, we've talked about syphilis ad nauseum, although you'll never see tabes dorsalis probably. You now know what it is and what column in the spinal cord it affects. But here you go. Cryptococcus is a common infection. It's a fungal infection that is in, when you say HIV, or when you say AIDS, when HIV has progressed to AIDS, one of the things that you always have to watch out for is this insidious infection in the CNS of AIDS patients, cryptococcus. Now, the next several slides, this is the only one I really want you to pay attention to, but the next several slides just get, if you want to plasticize it and keep it in your pocket for whatever reason on your clinical rotation, it's a good reference. If you look at spinal tap, and you're going to draw off CSF and do certain tests on it, obviously the test down here, different specific lab tests like polymerase chain reaction, looking for certain viral issues, cultures and sensitivity. These are things that are all very specific to the different types of bugs you're looking at. So what I want you to focus your attention to is on the top part. First of all, the top is the normal appearance. So the normal appearance of CSF is crystal clear, watery clear. If there is pus in the CSF from bacterial meningitis, it becomes turbid, cloudy. Viral meningitis, it can stay clear. The opening pressure, and you do put, and I think I mentioned this the other day, when you put the needle in, it has a stopcock on it. Did I mention this the other day? And you put the little manometer on it, and it gives you the opening pressure. Oh, because when I was talking about normal pressure hydrocephalus, normally it's 10 to 25. If it's bacterial meningitis, it will typically, the opening pressure will be elevated. In viral meningitis, it will be normal to elevated. Most of the time, it's normal. You're going to get a white blood cell count on the stuff. You run it right through a Coulter counter, just like you do blood. Normally, there should be just a few cells in CSF per microliter. In bacterial meningitis, you typically have a white count, and most of those white cells are going to be neutrophils. In aseptic meningitis, the range of WBC count is really variable. The thing is, though, these are typically lymphocytes versus, so you've got a left shift versus a right shift in the CSF. Two other valuable things that you're looking for are the glucose level and the protein level. So normally, these are the normal values up here. If you have an excess of viral particles in your CSF, then the protein level will usually be elevated. The same thing, if you have an excess of bacteria, you're going to have all that bacterial protein, it will be elevated. Protein level will be elevated. The difference here, though, is when you look at glucose. Bacteria metabolize glucose, so they will take the glucose that's normally there and start metabolizing it, so the glucose level in bacterial meningitis will be low. Viri don't use glucose, so the glucose level in viral meningitis will be the same as that you would normally find. Okay? So I have things here for, and there's a statement about cryptococcus and HIV. It's not really HIV, it's more in AIDS. Once the CD4 count gets below 200, that's when you really have to start watching out for fungal infections and abscesses in the brain. In fungal meningitis and in tuberculosis, and you typically have mostly normal findings because it's a slower process. In a subarachnoid hemorrhage, though, what you're looking for is an increase in the blood, not the white blood cell count, okay? One additional WBC per 1,000 RBCs is what you're looking for. Now, because of the metabolism of hemoglobin in the CSF, it's like a bruise. You get a bruise. What color does a bruise turn? It turns purple, it turns yellow, right? That's what happens in the CSF when you have an excess amount of blood there that's metabolizing that hemoglobin, xanthochromia, a yellowish appearance to it. Multiple sclerosis and Guillain-Barré are both neuromuscular diseases. You'll see here that you've got a normal lumbar puncture. Now, abscesses within the brain, cerebral abscesses, these are nasty little boogers. And most of the time you're going to encounter an abscess in the brain due in an immunocompromised patient. In particular, AIDS patients, and the bug there is toxoplasma. Remember we talked about toxoplasma in the OBGYN section. This is a pretty important thing. But once you get abscesses in the brain, typically they have to be drained and cultured to determine the bug. You're going to have to be on high-dose antibiotic therapy, specific antibiotic or antifungal or antiprotozoan therapy, which is what this is. The other protozoan that's kind of interesting that I thought about this weekend when I jumped into the lake to get on that inner tube was something like that. That's that brain-eating amoeba that gets up, you know, there was somebody that died here in Oklahoma recently. What lake was that?
Lake Murray.
Lake Murray. Because of the infection, this amoeba that's almost ubiquitous in warm fresh water, you get in there and it goes up your nose, goes to your respiratory epithelium, and next thing you know, you got the amoeba eating your brain and you're dead.
I drink my water from that.
Okay? Let's change focus here a little bit. Let's talk about a couple of things and we'll take a break. Delirium versus dementia. Delirium is usually a temporary, you will be asked on your boards to define these, to distinguish a patient with one or the other. So delirium is usually an acute condition of extreme confusion, agitation, that has a cause that you can correct, and the delirium will go away. You can recover from delirium. These are some of the reasons for delirium here. When a person comes into the emergency room, as you will see many times, one of the things you do is you give them what's called a rally pack, which is an IV, and the contents of the rally pack are this right here, and these vitamins here are turned the IV fluid yellow. That's why it's sometimes called a banana bag. It looks like a banana. It's yellow like a banana. So you give them this to help them recover from the delirium. Obviously, you're going to have to fix the problem with hyponatremia or some type of drug toxicity. PCP, you just have to let it ride. You know, there's no antidote for PCP. There's no antidote for methamphetamine. You just got to let, you know, you're gonna, other than snowing them with some Ativan or something like that, you just got to let it get out of the system. If you have never encountered a person who's on a 3-day meth binge, Rally Pack will be your friend, along with Ativan. Ativan is like Valium. It will settle you down. Okay, any questions?
So, the Rally Pack can correct all those causes?
No, it doesn't necessarily
Or
correct them.
get them through?
It will help them, help recover them for these things. You know, with a thiamine deficiency, and when we're talking about this later on, there's two types of, well, in alcoholism, and I mentioned this before, they get thiamine deficient, and you give them high doses of glucose to drop their, you cannot give an alcoholic glucose in a bag without hitting them with 150 milligrams of thiamine, because it can produce an encephalopathy. It has a specific name we'll get to later. Okay? And that's just part of the Rally Pack. Versus dementia, and obviously the most common form of dementia these days is Alzheimer's type. Alzheimer's dementia is a slowly progressing, irreversible problem that results in marked decreases in the thickness of the gyri and the increase in size of the sulci. So an Alzheimer's brain looks remarkably smaller than a normal brain. There are treatments to slow the progression of Alzheimer's disease. Usually those treatments involve increasing the amount of acetylcholine in the cerebral cortex, but these treatments usually are effective only for a certain number of years. They lose their effectiveness, and then you're at a point where the disease is just going to have to run its course, which is usually not very good. The anatomic feature of Alzheimer's disease that you find in autopsy are tangles and plaques. On histology of the brain, the presence of tangles and plaques is characteristic of Alzheimer's disease. There's a lot of amyloid that's also present. Then we mentioned amyloid as a waste protein when we're talking about the pancreatic islets. It also accumulates in the brains of Alzheimer's patients. Versus multi-infarct dementia, these are small infarcts, repeated infarcts coming off of thrombi in the carotid system or in the vertebral system that they're small enough that they don't produce an acute, significant stroke pattern, but over time they result in a dementia that's very similar to that seen in Alzheimer's patients. Any questions about that?
What age does it present?
Alzheimer's usually is going to present after the age of 70, but there is an early onset Alzheimer's disease. Who was the Tennessee basketball player, Pat Summitt?
Oh, yeah.
Pat Summitt, she was probably in her late 50s, early 60s. She just died. They say she died of Alzheimer's disease. Nobody dies of Alzheimer's disease. They die of complications of Alzheimer's disease, like they get pneumonia or something like that. Nobody dies of old age. You die because you got a heart attack or you got a stroke or something like that, but nobody dies of old age or Alzheimer's.
I had a grandma and she got diagnosed at like 45.
Yeah, it can happen very, very early. Now, there are other degenerative diseases that can happen at an early age, but you know, it's pretty devastating. I'm trying to figure out whether or not I want to do this or not, and I'll have to wait till after the neuro course, but that old guy I look after, right? You guys know about him, right? He has a moderately severe to severe Alzheimer's disease. So if I can't get his permission because he's not aware, so I'm struggling with ethically, can I do this? But I would like to show you an interaction with him. You know, he lives in his house, you know, with 24/7 attendant, but to get him to speak, you know, he'll say, well, who's coming over to stay tonight? I said, well, that'd be Kelly. Well, but who's coming over to stay tonight? Cindy? No, Kelly. Who's Kelly? Has she ever been here before? Yes, she was here last night. I mean, this is how you just get in these circles of discussion with him that can last a long time, and he cannot remember from 1 second to the next. So, you know, one of his people took him, one of his attendants took him to play golf, right? So he was putting at Lincoln in the afternoon at 3 o'clock, and by the time I got over there, 5 o'clock, he did not remember the last time he'd ever been to Lincoln Golf Course, but it must have been several decades ago. No, Don, it was just 2 hours ago. You were there, remember? No, you can't remember. This is a brilliant guy who was in insurance. He's a millionaire from his investments, and he's to this day now. So I'm torn though with the ethics on this. So he's 89. So physically, he's in great health.